Good morning or good evening, everyone. Let me introduce the first speaker, Dr. Susan Furth. She is a MD PhD, and she is currently is a vice chair of the Department of Pediatrics and the chief of the nephrology division at Children's Hospital of Philadelphia, and a professor of pediatrics and epidemiology at the University of Philadelphia. Dr. Furth received her MD degree from University of Pennsylvania. She completed her residency and fellowship at Johns Hopkins, where she also received her PhD in clinical investigation from Bloomberg School of Public Health. Dr. Furth is the principal investigator of the chronic kidney disease in children study, the largest multicenter prospective cohort study of children with chronic kidney disease ever conducted in North America, now in its 18th year. She has mentored many junior faculty who has progressed to successful research-oriented career in nephrology, urology, and rheumatology. And also she received a lot of awards. So let's welcome Dr. Susan. She wants to talk about the epidemiology and the database in chronic kidney disease in children. Okay.
Good morning. I'd like to thank the organizers for giving me the opportunity to present in this session about the chronic kidney disease in children study. The CKID study is an observational cohort study. We recruit children with chronic kidney disease up to the age of 16 at study entry from over 50 sites in the US and Canada. It's an observational cohort study. Our goals are to recruit and retain children with chronic kidney disease, to define risk factors for chronic kidney disease progression and the effects of kidney disease progression on cardiovascular disease risk, neurocognition, development, quality of life, and growth failure. The study was initiated in 2003. We recruited the first cohort starting in 2005. That cohort was 586 children with a median estimated GFR of 44. 3/4 of the children had non-glomerular diagnosis and a duration of CKD with a median of 8.6 years and an age of 10.9. To complement that group, in 2012, we started to recruit cohort 2. This was 305 children with a higher estimated GFR of 66 and a shorter duration of chronic kidney disease of 6.2 years. The median age of that group was 12. To further define the characteristics of childhood CKD, in 2017, we opened recruitment again and recruited an even younger group, all with non-glomerular disease, who had a median duration of CKD of 3.4 years, most of whom had CKD since birth. The outcomes of our study were really kidney replacement therapy, or alternatively, a 50% decline in GFR. We also looked at annualized GFR ratios, so the change over time in measured GFR. Initially, though kidney replacement therapy was a study endpoint, in our most recent iteration of the CKID study, we've continued to follow subjects through initiation of renal replacement therapy so we can characterize the effects of growth, the effects on growth, and as well as development, cognition, and cardiovascular disease risk. Even for those children that we've not been able to follow in person, we've developed a number of mechanisms so we can look at long-term outcomes as these children that we enroll become adults. We had, in 2013, instituted a mechanism for passive follow-up. Even if children could not come back for study visits, we allowed for phone or video visits. And at that time frame, we also added a consent to link the data from the CKID study to some existing registries, in particular, the US Renal Data System registry, where we will, many years from now, be able to ascertain long-term outcomes, including initiation of dialysis or transplant, need for dialysis again after transplant, and also potentially endpoints like mortality. We collect data at annual study visits, with the exception that the first year we do 2 visits in 6 months. You can see we alternate our focus on direct measures of kidney function and establishment of clinical phenotyping of cardiovascular disease risk factors, including ambulatory blood pressure monitoring, evaluating for dyslipidemia and effects on the heart with echocardiograms, and then also in-depth cognitive evaluation, behavioral assessment, Tanner staging, and at each visit, we biobank blood, plasma, serum, and urine for further studies. Over the years, CKID has made a number of seminal contributions to the study of chronic kidney disease in children. We've introduced methods to directly measure GFR with the plasma disappearance of iohexol, a number of means to estimate GFR accurately and precisely. We've defined risk factors for kidney disease progression, the prevalence of cardiovascular disease risk in children, as well as clarification on the evolution of bone and mineral disorders in CKD, and the effects on cognition and quality of life, and have most recently begun to partner with others to look at genetic contributions to structural kidney disorders, as well as genetic risk factors for progression. In 2009, we published a set of equations led by George Schwartz to estimate GFR in children. The updated bedside formula of 0.413 times the height over the serum creatinine has become a very useful tool. Additionally, we have a more in-depth formula outlined here that more precisely estimates GFR from creatinine and cystatin. In the current year, we just published in KI a new model to estimate GFR that has very little bias and is highly accurate up to age 25. And to do this, we used over 2,500 observations from almost 1,000 individuals, and we developed a creatinine-based equation and a cystatin-based equation that can vary with age and sex so that we get more accurate estimates. The graphical description of measured GFR compared to the creatinine-based estimated GFR here on the left panel, or the cystatin-based estimated GFR on the right, is illustrated here, showing very little bias and extremely high correlation for each of these equations across the age spectrum up to age 25. And we've made this calculator available online at the website illustrated here, where you can enter age, sex, and then either creatinine and height or cystatin and get an estimate of kidney function. Additionally, we recognize that proteinuria is a important risk factor for kidney disease progression. Different formulas use proteinuria or albuminuria to look at estimates of kidney function and also risk of progression. We've shown the correlation between levels of proteinuria and albuminuria in a more recent publication in AJKD in 2020, showing that we can use these measures almost interchangeably with these estimating equations. We partnered with the ESCAPE study to combine our data on children with chronic kidney disease with the children enrolled in ESCAPE, and we were able to classify children by level of GFR and baseline urine protein to creatinine ratio into different risk stages, with the lowest risk of renal failure, imminent renal failure, in those with the highest GFR and lowest level of proteinuria, and the most accelerated risk in those with lower levels of GFR and more advanced proteinuria. And we were able to use this data to develop a clinical tool that, according to risk group, gave providers and families estimates to the time needed before an individual would be at risk of developing renal failure. And this could be used in the clinical setting to help with planning for need for transplant or initiation of dialysis. In a paper back in 2015, we identified a number of biomarkers that predict rapid progression of kidney disease in children both with non-glomerular and glomerular disorders. And this slide shows those factors that are risk factors for a faster time to needing renal replacement therapy. Older age, male sex, both associated with a quicker need for renal replacement therapy, as well as elevated and nephrotic range proteinuria. That was in children both with non-glomerular and glomerular diseases, hypoalbuminemia, risk of elevated phosphate, as well as elevated blood pressure associated in all the children with higher risk of progression. Additionally, anemia and dyslipidemia were factors the estimates were similar in both populations, but statistically significant and associated with more rapid progression in children with non-glomerular disorders. We looked at factors of bone health and shown that elevations in FGF23 actually precede elevations in phosphate or intact PTH in children with CKD at every level of GFR. And based on this, we've also looked to see, we've shown that higher FGF23 levels are associated with more rapid progression. And as a result of this, a new clinical trial is currently underway to use phosphate binders early in the course of CKD to see if we can both lower FGF23 levels and slow progression to end-stage renal disease. As I mentioned, we partnered with ACPN to look at risk factors for progression. We also used our observational data and measured blood pressures in clinic to look at the correlation between achieved clinic blood pressure and kidney disease progression in children. And we've shown that based on our observational data in CKID, achieving a clinic blood pressure with systolic or diastolic blood pressure below the 75th percentile was associated with protection against renal failure. And so this actually adds to the existing ESCAPE trial where the direct measurement of blood pressure with 24-hour mean arterial pressure was the exposure, but sometimes difficult to obtain repeated measures of ambulatory blood pressure monitoring in children with CKD. So now we can target achieved clinic blood pressures as another parameter to try to slow progression. In looking at growth and factors associated with adverse growth in these children, we've shown, as others have, that lower CO2 is associated with poor growth and something that's potentially targetable to improve growth and other outcomes. And we've shown the associations between neurocognitive dysfunction and CKD, with a high proportion of our children, more than one standard deviation below the mean in a number of measures of performance IQ, particularly in block design and numerical operations, showing perhaps that some more complex intellectual operations are impacted by CKD. We've also shown, based on quality of life data, both from the child and parent perspective, that there are substantial impacts of CKD on children, particularly in school performance and also in overall health and social and emotional development. As we all know, in adults, cardiovascular disease remains one of the leading causes of death in children with end-stage kidney disease. So one of our goals in the CKID study has been to assess how cardiovascular disease risk factors evolve in the course of CKD. We've shown that elevated BP is highly prevalent in children with CKD, and we've seen evidence of target organ damage, both in left ventricular hypertrophy, with a dose-response relationship between normotension, masked hypertension, and confirmed hypertension, and LVH. Additionally, we've shown that higher levels of FGF23 and different tertiles of FGF23 are also associated with more elevated higher levels of left ventricular hypertrophy. Again, another compelling factor for the trial that I mentioned earlier to see if we can slow progression and actually also target adverse cardiovascular outcomes. Finally, we've partnered with a number of other investigators to look at the contributions of genetic disorders in chronic kidney disease in children, and have found that despite clinical diagnoses that weren't necessarily associated with genetic diagnoses, we found a number of previously unrecognized genetic disorders in our cohort, particularly in those with congenital urologic disease. And this slide illustrates a number of the discrepancies between clinical diagnoses of disease. For example, individuals thought to have FSGS or HUS, or non-specific diagnoses like reflux nephropathy or chronic GN or obstructive uropathy that have been found instead to have underlying genetic diagnoses. Additionally, many of the copy number variants and potential genomic disorders that we identified in the CKID study have also been associated with neuropsychiatric disorders, and partnering investigators have looked to see at the association between being a carrier for one of these genetic disorders and performance on our neurocognitive assessment, and have been able to show an association between having one of these genetic disorders and adverse effects on performance. Again, showing perhaps that there's an underlying genetic contribution to some of these deficits that we're seeing. Importantly, we were also able to show that interventions at the level of the child with more intensive learning opportunities and monitoring were able to mitigate some of the deficits that were otherwise seen in carriers of these genetic disorders. Finally, partnering with Neptune, we were able to show the risk of accelerated GFR decline associated with having high-risk APOL1 two high-risk alleles. And you can see here the dose-response relationship between having two high-risk alleles and a more accelerated decline in GFR, both in the CKID cohort and the Neptune cohort. Finally, I want to end by showing some of the opportunities that we've uncovered in the CKID study. Despite showing you'll see in this diamond plot on the lower right side, more advanced risk stages from A to F, we've shown that even in relatively low risk stages, we do have evidence of a number of cardiovascular risk factors, elevated blood pressure, high levels of phosphorus, high levels of acidosis and anemia that, although present at low levels of GFR, are not frequently treated as much as they could be. And we see gradually as kidney function declines, we see a higher proportion of the population treated with specific therapies for these disorders. But we see here in our observational study an opportunity to improve care for these children with chronic kidney disease, to improve their ultimate outcomes and slow their progression to end-stage disease. With that, I'd like to thank the organizers for giving me the opportunity to speak today, and I welcome any questions.
Thank you. Thank you for your wonderful talk. Do you have any questions in the audience, from audience? And online audience also.
So I can see the discussion forum if people would like to enter questions there. I did want to add that a couple of our more recent focuses in the CKID study, really one of the most remarkable findings, I think, of this cohort now that we've recruited over 1,000 children, is that even from a young age, a median age of 11, these children have a remarkable constellation of cardiovascular disease risk factors. And in addition to those that I mentioned in the talk with hypertension and left ventricular hypertrophy, we do see evidence very early of diastolic dysfunction, and we're continuing to evaluate target organ damage in the heart using cardiac MRI. And so those results are currently being analyzed. Additionally, we've examined, looked for vessel stiffness with pulse wave velocity. And though the good news is that we haven't found a great deal of increased stiffness, we have found, particularly in those children with high levels of proteinuria, we found some suggestion of more rapid pulse wave velocity. So showing that there's, again, even at a young age, some impact on the vasculature from in children with chronic kidney disease, particularly those with heavy proteinuria. The additional work that we're doing now in looking at risk factors for progression is looking at plasma and urine biomarkers that over and above estimated level of kidney function and proteinuria predict decline. And this is work that's being led by Dr. Jason Greenberg from Yale, partnering with me and Dr. Michelle Denberg in the Biomarkers Consortium. And we're finding that high levels of urinary and plasma KIM1 and plasma TNFR1 and TNFR2 predict chronic kidney disease progression. And urinary EGFR actually seems protective. So this work is now, we're hoping to develop panels of biomarkers that, in addition to creatinine or cystatin and levels of proteinuria, will be able to help us more accurately predict long-term outcomes for children with chronic kidney disease. And will also potentially, if we can identify patterns of children at high risk, allow us to select children that may be good candidates in trials of new therapies that may slow progression. So that's the general direction we're heading with our study.
Yeah, I'm very impressed for the wonderful result from your C-KID cohort. I want to ask you that in 2009, you said that you developed a new equation for the child to estimate the EGFR, right? And I think all of the cohort are from the CKD children, right? Do you have any non-CKD children contribute to the new equation development?
That's a really excellent question. No, the answer is that we have developed the equation within the C-KID study. So all of the participants did have some degree of chronic kidney disease. In 2009, the initial equation, those children did have more advanced kidney disease. So with a median GFR around 40. Now, with the equations that we most recently updated in just this year that are published in KI, we have children with much more mild kidney disease, so estimated GFRs as high as 90. So there is a broader spectrum of children with kidney disease, but your point is very well taken. I think our equations, having been developed in children with some element of chronic kidney disease, it is a little bit risky to apply them to the general population. We have seen in the past that our equations tend to underestimate kidney function in those with really normal function. So I think it's an important point to keep in mind. And I'm curious if that was the basis of your question as far as extrapolating these equations to the healthy population.
Yes, and in your cohort, do you have any Asian population?
Also, another important question. No, a fraction of, in the US, I think in our cohort about 70%, 75% self-report as Caucasian, and maybe another 25 to 30% as African American. And so there's a small proportion of individuals who identify as Asian American, and they would be from a large group. I think in the U.S., individuals who would identify as Asian could be from Southeast Asia, and very broadly. So that is another important point about extrapolating to a different population.
Another question is that, what do you think the diabetes contribute to the CKD in child?
In our study, actually, we didn't enroll any children who had CKD related to diabetes. In the U.S., I mean, traditionally, type 1 diabetes has been, and kidney disease related to type 1 diabetes has been quite uncommon. Unfortunately, we are seeing more and more type 2 diabetes and some associated kidney dysfunction in children with proteinuria, often early on, or albuminuria. But in our particular study, we have not enrolled many children with CKD secondary to diabetes, and it's not a largely prevalent population. Hopefully it won't be, but one has to be concerned with the prevalence of diabetes that we're seeing in the US.
Okay, any questions from the audience? So if no, and thank you, Dr. Susan Furth.